Well, good morning, everyone. I wanted to welcome you to this year's annual mid-year review. This is our 23rd year offering this comprehensive review of the latest updates and therapeutic advances in the treatment of malignancies. Here's our agenda for today, and there's copies up in the registration desk as well. I just wanted to go over a few housekeeping items. Please keep your cell phones muted throughout the event. After each presentation, we'll have 10 minutes for questions and answers, so feel free to ask our speakers your questions. The event is being recorded and will be uploaded to the event website at a later date. I also wanted to thank our valuable industry partners for joining our event today. The Nebraska Oncology Society would not be able to meet its mission without their partnership. This event is designed to present a comprehensive review of the latest updates and therapeutic advances in the treatment of malignancies. Continuing education credits will be available for this event. Complete the evaluation on our event homepage to get your certificate. The evaluation will be available next week, and you'll receive an email once the link is live. I will now turn it over to Dr. Stefano Tarantolo, our program chair and Nebraska Oncology Society president.
Thank you, Carmen. Thanks everyone for taking time out of your week to attend this meeting. So this has been going on for 23 years, and it's one of our previous partners, Pete Townley, actually is the person who kept us going for all those years. I'd like to thank the speakers for traveling to speak with us today. So it's my privilege to introduce Dr. Lamb. He's an assistant professor at Johns Hopkins University. He completed his fellowship at the University of Maryland and spent a short time at MD Anderson and realized the East Coast was much better. He's interested in lung cancer, bioinformatics, immunotherapy, and T-cell therapy. So with that, I'd like to introduce him and have him come to the microphone. Thank you for coming.
Great. All right. Good morning. Can you all hear me okay? It really is my privilege and honor to speak to this group today. Thank you for the organizers for inviting me to discuss lung cancer for our session. Oh, yeah, it's okay. I'll use the, I'll just use this. Okay, perfect. Here are my disclosures. So it would be impossible to try to cover all of the emerging data in lung cancer, even within, even within the day. But so for today's session, I would like to focus on emerging data for 4 key areas that impact our day-to-day practice, namely the rapid advances in resectable non-small cell lung cancer. These changes and emerging data for stage 2 to 3 resectable non-small cell lung cancer has really changed our practice in a truly multidisciplinary fashion, and is probably the area in lung cancer that has taken center stage over the past year. We'll also touch upon anti-Ctla4 immune checkpoint inhibitors and review some of the data to try to place these agents within context of our first-line treatment paradigm. We'll briefly review new data describing CNS activity of KRAS inhibitors, and then finally wrap up touching upon some of the advances in EGFR mutated non-small cell lung cancer, in particular since it has likely ramifications for other similar oncogenic-driven subtypes such as ALK and ROS1. So in the resectable setting, we have 3 FDA approvals, 1 in the neoadjuvant space, and then 2 adjuvant IO approvals for stage 2 to 3 non-small cell lung cancer. Checkmate 816 as you see at the bottom here on the left, really has been practice changing in terms of introducing neoadjuvant chemotherapy plus nivolumab, and has really animated our tumor board discussions and, for early stage lung cancer. And we'll talk a lot about 816. This year at ASCO and AACR, we saw for the first time readouts for the phase 3 perioperative studies. Aegean and Keynote 671 are notable. And these paradigms are really representing over the past year over 2,000 phase 3 clinical trial patients that are being reported out just within the past year. Now, if we dive a little bit deeper into the actual current landscape for resectable non-small cell lung cancer, this is what it looks like. So at the top here, Checkmate 816, again, as you are familiar, chemotherapy plus nivolumab for 3 cycles, then to surgery, and then you're done. We also have approvals in the adjuvant space. So Empower 010, giving us atezolizumab for a year for tumors with PD-L1 greater or equal to 1%. And then we also have more recently pembrolizumab in the adjuvant setting for a year as well. At the bottom are ongoing studies looking at these approaches, but in the perioperative approach, meaning neoadjuvant chemo IO, surgery, then adjuvant IO, generally for about a year. And so we'll focus on 2 key studies that reported out this year at ASCO and AACR, Keynote 671 and Aegean. So as you recall, Checkmate 816 was a randomized phase 3 study that looked at a neoadjuvant approach of chemotherapy plus nivolumab for 3 cycles versus standard of care chemotherapy before surgery. And it was a very positive study with regard to its 2 primary endpoints. On the left here, pathologic response. So you can see patients in the nivolumab chemotherapy arm had an increased rate of pathologic response, complete pathologic response actually of 24% compared to 2% for the chemotherapy arm. And then importantly, we also saw survival benefit that corresponded with this pathologic response. So on the right, event-free survival. And this is the updated 3-year survival data that was presented at ELCC earlier this year. And you can see that the event-free survival benefit that we saw initially has been sustained with a 57% event-free survival for the intervention arm compared to 43% and a hazard ratio of 0.68. So really affirming this approach as an important standard of care for resectable non-small cell lung cancer. Now, do some groups do better than others with this approach? From the subgroup analysis, it appears that that is indeed the case, although I would caution that as far as randomized phase 3 studies go, this is a relatively small study with only, about 300 plus patients or so. So these subgroup analyses results really should be taken with a huge grain of salt. But most of these trends do make sense. For instance, we see that later stage patients, stage 3A patients, tend to do better with this approach. Non-squamous patients, patients with high PD-L1. And interestingly, at the bottom there, you see that carboplatin, patients who receive carboplatin as part of their chemotherapy regimen actually seem to do okay. And this is a common question we get, can you use carboplatin instead of cisplatin, assuming there's no shortage, of course. But it's important to note with this carboplatin trend here that in this study, carboplatin was paired with paclitaxel. So this may actually be more representative of the efficacy of paclitaxel than actual carboplatin. For the astute viewers, you might notice that never smokers, actually somewhere towards the middle, tended to do extremely well with a hazard ratio of 0.34. And I did not highlight this in red because, again, I'm not quite sure that this would hold up in a larger set, especially with this population where never smokers meant EGFR and ALK wild type. So what about the adjuvant setting? Well, this is the data for adjuvant pembrolizumab, which is the newest kid on the block. This is the Keynote-091 Pearl study, randomized patients with stage 1B to 3A per the 7th edition staging, resectable patients to either pembrolizumab for a year after surgery or placebo, with primary endpoints of disease-free survival in the overall population and then in the PD-L1 high population. And this study was a positive study with the first co-primary endpoint with improved disease-free survival for the overall intent to treat population, as you see on the left, with a hazard ratio of 0.76, favoring patients who got adjuvant pembrolizumab as opposed to placebo. Interestingly and unexpectedly, on the right, you'll notice that patients with high PD-L1 did not have the same disease-free survival benefit. This was not an expected result, and most likely reflects some unknown imbalances in the groups, but this really was not something that anybody expected. But regardless, the FDA did approve this and gave a label for adjuvant pembrolizumab earlier this year, agnostic of PD-L1 status. And that approval came on the heels of adjuvant atezolizumab, which we already had a label for. And this is updated results presented late last year from the Empower 010 study that evaluated adjuvant atezolizumab. And you see here, consistent with prior disease-free survival results, we actually have initial overall survival results that are consistent. Namely, on the left, patients with PD-L1 positive tumors did achieve an overall survival benefit of 0.71 with adjuvant atezolizumab for a year. But you'll notice on the right that this benefit is quite marked for patients who are of high PD-L1 status with TPS greater or equal to 50, hazard ratio of 0.42. In fact, in Europe, the regulatory bodies have approved adjuvant atezolizumab only for high PD-L1 tumors. And then finally, we're seeing the initial data for the peri-op studies. Again, these are neoadjuvant chemo IO, followed by adjuvant IO as well. So Keynote 671 was presented at ASCO this year, and this was a relatively large study of almost 800 patients, randomizing resectable patients to chemotherapy plus pembrolizumab, followed by adjuvant pembrolizumab for a year versus chemotherapy plus placebo, and then adjuvant placebo with primary endpoints of event-free survival. And this was a positive study. And similar to Checkmate 816, we saw that there was a path CR benefit with increased rates of complete pathologic response for the pembrolizumab arm at 18% compared to 4% for just chemotherapy. And then with regard to the primary endpoint of event-free survival, we saw a hazard ratio of 0.58. Really, again, consistent with what we saw with the neoadjuvant results in terms of event-free survival. Now, of course, if we add more immunotherapy onto the treatment paradigm for resectable disease, the concern here is potential for additional toxicity. And here, if you dive into the supplemental of the publication, you do notice that there may be a signal here that definitely bears watching. There was increased rates of grade 3 to 5 adverse events that were treatment related, including 1 death. And you'll notice that this is almost double the rate compared to the placebo group. Fortunately, in the neoadjuvant phase of the study, there does not appear to be any significant additional toxicity, namely, there was no significant increase in patients not getting the definitive surgery. Again, similar to what we had seen with Checkmate 816. The other perioperative randomized phase 3 trial that read out this year was Aegean, and again, a rather large study of over 800 patients, this time randomizing patients to chemotherapy plus durvalumab, followed by adjuvant durvalumab for a year versus placebo. And primary endpoints here included path-CR as well as event-free survival. And again, consistent with the prior neoadjuvant and peri-op data that we just saw, there was indeed a pathological complete response benefit when you add immunotherapy to chemotherapy up front. And then also we see an event-free survival. This is relatively immature with only 32% EFS events at this point. But even at this early stage, you see a hazard ratio of 0.68. That's highly statistically significant. Similar to what we saw with the other peri-op data with Keynote 671, there's also, some safety data that bears close follow-up. In this particular study, there was 5 excess deaths that were possibly treatment-related, and increased rates of grade 3 to 4 treatment-related immune related toxicities. This, of course, is really an important point for this setting where, this is a curative setting. So any excess death or delay in patients getting to surgery really is problematic for regimens that are being considered for this setting. So putting it all together, how do we figure out what's the best approach in our tumor boards for our resectable patients? Well, if we just look at the neoadjuvant and the perioperative data, it's interesting to note that the path-CR rates are really not that different, which is really nice to see because it seems like the neoadjuvant addition of IO fairly consistently improves path-CR. If you look at the survival data in terms of event-free survival or disease-free survival, there's also not a tremendous difference within the neoadjuvant and the perioperative data. So it's really not clear how much more at this point, how much more the additional adjuvant portion of immunotherapy adds to survival, but we await, further maturity of this data. If you just want to compare the FDA approved options that are available in red, namely neoadjuvant approach versus adjuvant, again, if you look at the EFS and DFS data, not a tremendous difference. And it's important to note that for the Empower 010 data, that's for a biomarker or a PD-L1 selected population. So my approach really is, given the data as it stands now, is to favor Checkmate 816 in terms of currently available therapies, in the absence of any clear survival advantage of the adjuvant approach at this point. So 3 cycles up front of chemo IO, then surgery, then you're done, seems a lot more appealing than, adjuvant chemotherapy, and then a year's worth of immunotherapy for most of our patients. And there's biologic rationale to suggest that a neoadjuvant approach is actually potentially better. You can imagine that having the tumor still intact gives rise to a rich and diverse set of neoantigens, potentially even enhanced by immunogenic cell death. And indeed, in this really pivotal article, we're seeing for the first time clinical data to potentially support that hypothesis, at least in melanoma. So this was a randomized phase 2 study in locally advanced resectable melanoma conducted by our colleagues at MD Anderson, in which they randomized patients to neoadjuvant pembro as well as adjuvant pembro versus just the standard care adjuvant pembro. And you see here that there's a significant difference in event-free survival, benefiting patients who got the neoadjuvant pembro as well, with an event-free survival at 2 years at 72% compared to 49%. So it'll be really interesting to see whether or not this holds true in the lung space as well. But it does give a lot of support for those of us who think that neoadjuvant IO is an important component in this setting. Now, switching gears to advanced stage non-small cell lung cancer, really looking at some of the data for anti-Ctla4 immune checkpoint inhibitors. So in terms of the first line immunotherapy space for advanced non-small cell lung cancer, we have 12 FDA approvals that you can pick from. And really, one of the common questions that come up in clinic really is how we fit the anti-Ctla4 regimens that are currently available within this paradigm. Is there really any reason to move off of the workhorse of Keynote 189 or 407 and the other pembrolizumab based regimens? And so here's some recent data that may be helpful in this regard. So as you recall, Checkmate 9LA was a randomized phase 3 study that evaluated the combination of chemotherapy plus ipilimumab plus nivolumab for 2 cycles, followed by maintenance nivo-ipi, compared with just standard of care chemotherapy and optional pemetrexed maintenance. And this was a positive study with an overall survival benefit for the chemo plus ipi-nivo intervention, leading to an FDA approval in 2020. And here we see at ASCO updated overall survival data at 4 years, showing that overall survival benefit is sustained with an hazard ratio of 0.74 and overall survival at 4 years at 21%, really trending towards that sort of magical 20% number at 5-year overall survival that we're seeing with Keynote 189 and other established chemo IO regimens. And consistent with what was previously reported with Checkmate 9LA, it seems to have differential sensitivity for some subgroups, in particular PD-L1 low, with a hazard ratio of 0.66 for overall survival here, compared to 0.74 for PD-L1 positive. Also for squamous with a hazard ratio of 0.64 compared to 0.80 for non-squamous. They did not show updated overall survival data for the subgroup of patients with brain metastasis, and that was the third subgroup that was initially reported to potentially, that may potentially benefit specifically with Checkmate 9LA. And importantly, with this updated overall survival data, we see that patients who discontinued treatment due to toxicity, namely immune-related toxicity, still continued to derive benefit from this treatment. So you see at the 4-year mark, overall survival rate of 41%, which is actually better than the overall intent to treat population, with an overall survival rate of 21% at that point. So this is reassuring for those of us who do use anti-CTLA4 and are concerned about the additional toxicity that this sort of approach does introduce. And of course, naturally, the thought is, well, if it helps PD-L1 negative patients, can anti-CTLA4 immune checkpoint inhibition and its T cell priming properties help other immune cold subtypes, such as STK11 or KEAP1 mutated non-small cell lung cancer? These subtypes are associated with poor prognosis, as well as decreased tumor infiltrating T cells. And so this is a nice retrospective analysis using Flatiron data comprising over 2,200 patients. And you can see here that it's demonstrating that patients with KEAP1 mutations or STK11 mutations, or even both, do particularly poor in terms of overall survival, regardless of whether or not they received first-line immunotherapy-based regimen or just platinum-based chemotherapy in the first line. And so the newer kid on the block in terms of anti-CTLA4 regimens that are available to us is Poseidon. And Poseidon indeed actually has some signals to suggest that it may be able to address some of these immune cold subtypes. So as you may be aware, Poseidon is a randomized phase 3 study that randomizes patients to actually 3 arms. And the top one is the one that we're focusing on, which is Durva plus Tremi plus chemo for 4 cycles, and then an additional cycle of the CTLA4 Tremi, and then maintenance Durva. Patients were also randomized to Durva plus chemo, but that arm, while positive for PFS, was not positive for OS. And so the FDA approval was indeed for the Durva plus Tremi plus chemo arm. And that was based on this overall survival benefit that you see here on the left with a hazard ratio of 0.75. And you'll note that, as I mentioned earlier, just the Durva and chemo did not reach statistical significance for overall survival. And it's interesting to sort of compare the subgroup analyses for this anti-CTLA4 regimen in comparison, for instance, with Checkmate 9LA. So the subgroups in gray here are the ones that we saw previously worked preferentially better for Checkmate 9LA. And interestingly, we don't actually see those same trends with Poseidon, namely low PD-L1, squamous, and patients with brain mets. Interestingly, non-squamous actually did better with this particular CTLA4 regimen. And so indeed, we do see that Durva plus Tremi plus chemo seems to be helpful for patients with these tumor immune cold subtypes like STK11, with a hazard ratio here of 0.62 compared to 0.70 for STK11 wild type. But keep in mind, for the other chemo IO regimens, really survival benefit for STK11, for instance, is really generally quite poor. This difference is even more remarkable for KEAP1 mutants with a hazard ratio of 0.43. Of course, significant caution here that these numbers are very small. This is exploratory, not pre-specified subgroup analysis. So you'll have to take this with a grain of salt, but there appears to be a potential for some differential sensitivity here. Same thing for KRAS mutants as well, with a hazard ratio of 0.55. And again, if we compare with our other CTLA4 regimen of Checkmate 9LA, we do see similar trends, again, with KRAS mutants with a hazard ratio of 0.72, STK11 with 0.79. They don't actually report the KEAP1 mutants, but there was a trend also for improved survival for these subgroups, although not to the same magnitude as we saw with Poseidon. And of course, when we add another immune checkpoint inhibitor, toxicity is a major concern and is probably this, the primary barrier for adoption of this particular regimen. And you do see that there are indeed increased rates of treatment-related serious adverse events with the anti-Ctla4 regimen, 27.6% as compared to 19.5% with just the Durva plus chemo, and with some additional grade 5 events as well. So how do we put this all together in the first line advanced non-small cell lung cancer space? Well, for me, the workhorse still remains the pembrolizumab based regimens. So for high PD-L1, pembrolizumab monotherapy is what we often use. And of course, for other patients, chemo IO with Keynote 189 or 407 for our squamous patients. However, with this new data for CheckMate 9LA and Poseidon, I do strongly consider CheckMate 9LA for our patients with PD-L1 negative tumors who are fit for anti-Ctla4 therapy. And then the subgroups of brain mets and squamous, I'm not as clear about, and I haven't really fully adopted because the biologic rationale for that hasn't quite been clearly elucidated. For Poseidon, I do actually consider that regimen for patients with STK11 and KEAP1 mutants at this point, fully acknowledging that the subgroup analyses are quite preliminary and really should be considered hypothesis generating, but this is really more, I guess, in the setting of a subgroup that really has truly poor prognosis. So it's nice to have this additional option. And then one last note before we move off of immunotherapy for advanced non-small cell lung cancer. This was a poster at ASCO that was simultaneously published in JAMA Onc recently. Really important retrospective data here that helps answer the question of whether or not you should continue immunotherapy past 2 years. As you know, we really have a paucity of data in this area, especially prospective data. So this was, again, a flat iron retrospective analysis of over 700 patients, comparing patients who stopped their immunotherapy-based first-line regimen at 2 years versus those who continued indefinitely. And you see on the left that there was no difference in overall survival in this retrospective analysis. And then the plot on the right, the swimmer's plot on the right, simply aims to show you the 11 patients that had stopped at 2 years, but then got re-challenged because of recurrent disease or progressive disease. Those patients actually did derive a benefit from the re-challenge of the immune checkpoint inhibitor, at least with stable disease or better. So I think this is really an important analysis. Of course, caveats surrounding the retrospective aspect of this, but we won't be getting any prospective data looking at this specific question anytime soon. So I do think that this can inform practice for that important question. And then, so moving on to targeted therapies, and it's really great to be able to add KRAS to this section now. I just wanted to briefly touch upon brain brain met activity for the KRAS inhibitors, because this has sort of been a question that's been floating around as we've begun to adopt KRAS inhibitors more broadly in our practices. So in the initial publication of adagrasib from the CRYSTAL-1 study, we did see that there was a preliminary hint of objective response, intracranial objective response for adagrasib at a rate of 33%. But the CNS activity of sotorasib, which is arguably at this point the most popular KRAS inhibitor used in lung cancer right now, the CNS activity of sotorasib is quite uncertain. At ASCO, we did have some data to help with this, and this was a post hoc analysis of the CodeBreak 200 study, which was the randomized study looking at sotorasib versus docetaxel in the second line. And so you see here on the left that patients that got sotorasib actually had improved median CNS progression-free survival with a hazard ratio of 0.63. And then on the right, again, fairly small numbers once you actually got down to patients who actually had measurable disease, only 18 patients, for instance, on the sotorasib arm. But with that, you see an objective response rate in the brain of 33.3%, which happens to exactly be what adagrasib reported initially. And then adagrasib updated its CNS data with a JCO brief article recently, this time looking at only patients that had untreated brain mets in their phase 1 studies, again, showing a nice response with an objective response rate of 42%. The nice thing is that these objective responses in the brain are fairly concordant with the systemic response, suggesting a good sort of plasma CSF level for these inhibitors. Now, these objective responses are not in the 70 to 80% range that we would see for instance, EGFR or ALK. So for our KRAS patients, local therapy considerations such as SRS are, really still remain quite important. And then finally, to wrap up, we'll talk about some key advances in EGFR, in particular because of its ramifications for the other oncogenic-driven subtypes. As you've probably heard, the big splash in lung, at least for ASCO, is the plenary presentation of the ADAURA overall survival data. So ADAURA is the randomized phase 3 study that evaluated adjuvant osimertinib for resected EGFR positive non-small cell lung cancer. And this adjuvant regimen was continued for 3 years. This was positive for disease-free survival as previously reported. But of course, and it was quite positive with a hazard ratio of 0.27 in the updated analysis. And then importantly, as you see at the bottom here, very similar benefit in the brain. And it is thought that a lot of the benefit that's derived from adjuvant TKI in the setting is from, protecting against brain metastases. But of course, the big question here that people were holding out for was, is there an actual overall survival benefit? And sure enough, we do see an overall survival benefit with a hazard ratio of 0.49. That's highly statistically significant. 5 years, patients who received adjuvant osimertinib had an absolute 10% difference in terms of overall survival compared to placebo. The biggest, just looking at subgroup analysis, as we've seen previously with osimertinib, patients with exon 19 deletion did especially well. And it was good to see that the overall survival benefit was irrespective of whether or not patients receive adjuvant chemotherapy, because that was not mandated in this study, although really best practice is to still do adjuvant chemotherapy and then start the TKI. Of course, the big critique that you may have heard about this was the fact that crossover rate was actually quite poor. Only about 38% of patients in the control arm who recurred actually then got put on osimertinib. And so unfortunately, this study does not answer really the critical question of sequencing. Would it be just as good to hold off on osimertinib until recurrence in terms of overall survival? Unfortunately, we do not get that answer from the study, but given its significant overall survival benefit, this is indeed considered the new standard of care by most of us in the field. And then just a brief note about another piece of data from ASCO that gives us a little bit more data about the role of immunotherapy in an EGFR. This is Keynote 7889, which randomized patients to chemotherapy plus Pembro after TKI resistance versus just standard of care chemotherapy. And then we know that immunotherapy for EGFR generally does not work, but there are some privileged subgroups within EGFR for which it seems to work, maybe high PD-L1, for example. So in this particular trial, it was stratified for PD-L1, so that was quite balanced. And it's also interesting to note that about half of the patients actually got something other than osimertinib before TKI resistance. And so we see here with KEYNOTE-789 that there was no survival benefit at all with adding pembrolizumab to chemotherapy after patients have progressed on their TKI, regardless of PD-L1 status. So I think this really puts to bed any thought that immunotherapy, at least anti-PD-1 therapy, has any role in EGFR positive non-small cell lung cancer, maybe in conjunction with VEGF, which we've seen previously with Empower 150, for example, but that's questionable as well. And then finally, just wanted to note the next sort of sea change that's coming in this space, which is that FLAURA2, the randomized phase 3 study that evaluated the addition of chemotherapy plus osimertinib versus just osimertinib by itself for our newly diagnosed EGFR positive patients. They announced via press release that that was a positive study based on the primary endpoint of PFS. And this comes sort of on the heels of previous data that we've seen, but though with gefitinib, suggesting that the addition of chemotherapy plus TKI indeed can improve at least PFS, so the overall survival is not quite clear. Of course, the big question here is, would you adopt this standard with simply a PFS benefit, or do you need to see an overall survival benefit in this setting? So to wrap up, a lot's been going on in lung cancer over the past year, but I think nothing has moved more rapidly over the past year than the data in the resectable setting. So neoadjuvant chemo I believe firmly really should be considered for all chemo-eligible EGFR ALK wild-type patients. Important to note in terms of logistics, this sort of neoadjuvant approach really puts a lot of pressure and strain on our mechanisms for obtaining timely biomarker status for our resectable patients. Being able to get the EGFR and ALK status for the patient who just wants to go to surgery right away is very much a challenge for all of us. But I think it'll be required as we get more and more data in this space. Anti-Ctla4, I believe, can be quite helpful for certain subsets of advanced non-small cell lung cancer, in particular PD-L1 negative patients, and perhaps STK11 KEAP1 mutants as well. CNS activity is indeed, has been seen for our currently available KRAS inhibitors. And then finally, all of the adjuvant and first-line chemotherapy combination data that we're seeing for EGFR really represents a change in our paradigm and undoubtedly will impact our patients that have other oncogenic-driven subtypes like ALK, ROS1, RET, because these patients are already in our clinic asking for the same approach. So with that, I'd like to thank you for your kind attention. Happy to take questions if we have time. Yes.
Any changes in the management of small cell lung cancer?
Unfortunately, not any significant changes. We did see data from the SWOG study. I forget the exact number that looked at the combination of PARP plus chemotherapy plus immunotherapy for patients with Schlefin-11 positivity, and that's considered to be a biomarker for PARP sensitivity in small cell, and that did show an initial signal for PFS benefit, but it was modest. Otherwise, I think Other exciting areas in the small cell space include the bispecifics, of which those data should be coming out maybe next year. For instance, the Amgen bispecific targeting DLL3. Those sort of immunotherapy-based approaches, novel immunotherapy-based approaches, I think are quite promising.
So if you have a advanced stage metastatic small cell lung cancer without CNS metastasis, you do the treatment with chemotherapy and immunotherapy, and you go on with immunotherapy, and they still don't have CNS metastasis. Do you still do the prophylactic, or how do you look at the prophylactic? Elderly patients, we know that performance levels declines quite often after radiation. How do you look at this one?
Yeah, that's still an area of controversy. As you know, there's some significant critique about the prophylactic cranial irradiation for extensive stage small cell patients based on Japanese data that showed that benefit may not be there if you actually have MRI screening of these patients at baseline. Personally, I think where you fall on this debate depends on whether you're a medical oncologist or a radiation oncologist. I think that a lot of our radiation oncologists still are proponents of prophylactic radiation for the brain for extensive stage patients. A lot of our medical oncology colleagues, including myself, I don't favor it. And unfortunately, I think in part there may be some nihilism that's part of this, but also I think based on data that shows that it doesn't significantly, it clearly has an impact on quality of life, especially for our patients who are older. Yeah, it's a favorite subject of mine, and this is we did a lot of this when I was at Anderson, and we were flailing around quite a bit, really not seeing a lot of signal. Clearly not the same efficacy that we're seeing with the hematology, the heme malignancies. But really, I can say we're finally seeing some progress in the T-cell therapies for solid tumors. Not specifically for lung cancer yet, but for solid tumors, for instance, I think that maybe within the next year or so, there will be potentially an approval for TCR therapy for the first solid tumor TCR therapy, which would be for synovial sarcoma. But there's a lot of activity going on in the space. There's also potential signal for TCR therapy for gastroesophageal and other tumor types. But we also have TILs that are being investigated specifically for non-small cell lung cancer, actually for EGFR, ALK, and oncogenic-driven subtypes as well. So still early days, but we're, I think, maybe starting to turn the corner, and we should see some clinical responses maybe, hopefully, in the next few years. Yes. Oh, that's a great question. My focus actually is on ALK, which is sort of a cousin of EGFR and shares a lot of the same properties. We presented data at ASCO that showed that for these tumors, and we looked at over 500 ALK tumors that had KRAS tested and did a transcriptomic analysis, and showed that these tumors in general are inert, primarily because there are very little CD8 cells that are infiltrating. And so why are there low CD8 cells? Well, that's the million-dollar question. We do know that these tumors generally have low tumor mutation burden. So that may be a strong factor. I think a key factor is that these tumors are so quiet, so to speak, to the immune system. They are so related to self that there really does not generate a lot of neoantigens. These tumors do not present significant neoantigens to the immune, to initiate an immune response. So I think a lot of the efforts to target these tumors with immunotherapy really should be focused on sort of enhancing tumor infiltration, either with like CD73 based approaches. CD73 adenosine pathway acts as sort of like a wet blanket for immunotherapy responses, or sort of manually doing it with brute force with T-cell therapy or vaccines. And vaccines is one approach that we're developing for this tumor type.
Thank you very much.
Thanks.
Thank you so much, Dr. Lamb.